Good evening, everyone. Welcome to our RACGP members and friends, family joining us online, online or here in the office for tonight's communicable diseases update for NT General practitioners. We're grateful to Dr Hayley Dyke, Head of Surveillance Response, Centre for Disease Control, for your time tonight facilitating this event for us. This event will be recorded, so those that couldn't attend tonight, you can watch later at your leisure. We'll just move on. We'll do an acknowledgement of country. Before we begin, on behalf of RACGP, I'd like to acknowledge the traditional custodians of the lands and waterways in which we work and live. We recognise the continuing connection to land, water, culture, and pay our respects to elders past, present and future. We'd also like to acknowledge any Aboriginal or Torres Strait Islander people who are joining us this evening and extend our respect to them as well. Tonight, it's my pleasure to introduce Dr Hayley Dyke, again, Head of Surveillance Response, CDC. I'd actually like to hand over to Hayley just to a little bit of an introduction to herself, if that's okay.
Thanks so much. And I also acknowledge the traditional owners of the lands we're meeting on today, beautiful Arakaea country. I think it's a real privilege to be able to sit here and gather today and share information, share knowledge the way that's been done for tens of thousands of years. Pay respects and grateful to be here. So I'm a public health physician, so doctor training pathway through to public health medicine as a specialty, but also epidemiologist. I did a Master of Applied Epidemiology because I, for a minute, thought that I was done with medicine and wanted to be an epi, and then got sucked back into it. Now I'm both. So my job at the NT CDC is a sort of crossover in supervising public health responses and looking at population impacts of notifiable diseases, but also managing data systems and looking at data. And a lot of my job at the moment is consultation and thinking about data. So it's a really interesting combination. Before I was in Darwin, I was in Tasmania for a few years, Cairns before that, Albury-Wodonga before that, and trained in Wollongong. So been a little bit everywhere, and very hopeful that it kind of helps with the job that I'm doing now. So I'll leave that there.
Great, thank you for that. For those of you that are joining us online this evening, just please note that your microphones and cameras have been turned off just to reduce noise. We will have some questions later at the end of the session that Dr. Hayley is more than welcome to answer. If you could submit any of your questions via the Q&A, that would be great. I will just hand over and we'll get ready. Just give us a moment if you don't mind. We'll just bring up the presentation. Thank you.
Thanks very much. All right, I don't need to do this intro slide. We already did it. Yes, tonight we're doing the communicable disease update for NTGP. So there was a few diseases promised in the program, which I will cover, but then hopefully I'll try and get through this a little bit more quickly so we can spend more time. Oh, thank you so much. On questions and answers at the end, and honestly happy to take Q&A about anything, not just what's in the slides today. So the CDC has a number of programs and units contained inside of it. So the Surveillance and Response Unit, which is mine, does notifiable diseases and public health response. We've also got immunisation, who I'm sure you're very familiar with, who probably come and do these all the time. We've got sexual health services, so that's two separate sort of units. We've got the sexual health and bloodborne virus unit that really looks at health promotion, kind of that bigger picture operational oversight of sexual health in the NT. And then there was also clinical services, so Clinic 34, that runs out of each of the 5 offices in each of the regions that hopefully you're also familiar with. And if not, we'll get them to come and have a chat with you too. We've got TB and leprosy clinics that run out of all of these offices as well in Alice Springs, Tennant Creek, Nhulunbuy, Katherine and Darwin. We've got a rheumatic heart disease team that looks at particularly the strategy of trying to reduce acute rheumatic fever and rheumatic heart disease in the NT, which is really no small feat at all. We also have a team trying to eliminate trachoma and really moving into a new phase of things this year, which is very exciting. We've got medical entomology, or the Mozzie mob, who look at mosquitoes, look at bugs. They get out on the ground, they trap bugs, they look at them under microscopes, do like real actual sciencey stuff. They do great work. And then the newest unit is the STI and BBB and immunisation strategy and policy team, who used to report to the Chief Health Officer directly. Because they work so much with the teams in our unit, they've come over and now they sit under our CDC umbrella as well. So lots of things going on in the CDC than just notifying diseases and counting stuff like I do all day. So as I said, we've got offices everywhere throughout the NT, some bigger than others. And that contact detail, sorry, that's just the Darwin one. It's just our standard for here. But also we're available after hours. So I'm actually on call, phone's in pocket, hoping it doesn't go off. But every night of the week, every public holiday and weekend, you can call us through any of the hospital switch numbers, and we can help you with a bunch of stuff. So I'll point out through this talk some of the ways that we actually can after hours. So what do we do? What does CDC do? So we monitor and prevent and control communicable diseases in the Northern Territory. We try to do that through assisting NT health providers everywhere to provide healthcare in the Northern Territory by supplying information, supplying resources, helping out with contact tracing. Unfortunately, we don't have teams we can parachute in or deploy. We'd love to be able to do that, but we can sort of support everyone who is present to look at preventing and trying to improve health in communities. So we communicate with clinicians, we communicate with policymakers, we're doing ministerial briefs and thinking about politics and politicians more often than probably like to. And we also talk to the general public in lots of ways, through radio, through social media, directly face-to-face. Our public health unit in Darwin's based at the hospital, so my team every day are walking over to the hospital and seeing people and their families and doing that communication directly. Don't know if this QR code's big enough, but hopefully it is. If you scan it, it'll take you to this page that I've just screenshot here, which is our public-facing public health and notifiable diseases page. And so on here, there's a bunch of links to lots of things. So for notifiable diseases that are notifiable by clinicians, if you don't want to talk to us on the phone, that's okay. You can download this reporting form, fill it out and email it to us. We've got links here to the timeout poster and other resources in the library, and for Josie in the room, we've got some hard copies to take home, but I'll leave them here too so they can be handed out at education sessions if you want to pick one up, or we can post them out to you as well if you'd really like one. The other thing on this page is a long list of diseases. So we've just got a couple of them cut off right at the bottom there, but it's a long list of all our 101 notifiable diseases, plus a few bonuses and extras, things like head lice, black cheek, hand, foot and mouth disease, worms. There's some other bonuses on there that we've put resources up to try to give you all some help and somewhere to go for fact sheets for other kinds of resources and information. So if you click on one of those, I've just used the top one, APSGN as the example, takes you to a page, another page with more links. But this one actually takes you to the resources. And so we've got, regular fact sheets that we try to have as simple language as we possibly can. And some are designed for health professionals and others for the general public directly. And so then some of them have picture resources or other kinds of things like this one. Crusted scabies is another example with some sort of picture things. You can put them up, print them, post them on your walls, hand them out to patients, whatever you'd like to do with them, you're free to. And for crusted scabies as well, One Disease did One Disease made a series of videos about crusted scabies, and they're all in different language. So it's a video to play if you've got, assuming no one's got the heaps of time, but potentially you can send patients home with something to watch about crusted scabies and what happens in hospital if you have to go and all that kind of information. So lots of things on our website. So other things that we put out, we do publications regularly. So the first one there, the surveillance update, that is my job and it is behind, and I'm very sorry. I haven't done one since February. I'm about to do 2 in quick succession. But those come out monthly and just kind of try to keep them short, 3-page snapshot of what's been happening in the last month and what's important for the NT. So, that example at the start of the year, melioid is always sort of up, and return travellers after holiday periods, we tend to put those out and give some reminders and tips in there. Also got the Disease Control Bulletin. So it is a journal. It's not sort of like a peer reviewed journal in the same ways like ANZ or JPH is, but it's a local journal that has been going since the 90s and focuses on the Northern Territory. And what we do here is it's actually a really great like repository of like history keeping and record keeping of what has happened over time in the NT, what we've done in the past, things that have worked, things that maybe haven't worked. And we've just finished working with library to make it searchable now. So hopefully it's a little easier to find things. But anyone is welcome to actually put things in if you've got something that is interesting to the NT, but maybe you think it's not sort of nationally publishable, send it to us so we can record what's happening here. There's some other updates. Immunisation put out a regular one, and the sexual health surveillance update goes out every 6 months. There's lots of things coming out. One of the other things we put out, hopefully everyone has seen maybe one of these before at some point, is the health alerts. So we don't author all of them, but our page hosts health alerts generally. So we've got some examples of these. So we've got increases in pertussis, increase in syphilis in the Top End and Katherine regions at the end of last year. We'll put out a health alert, and we do push those into the emails of every practice manager and to PHN, to anyone we can think of, to try to get the word out there that there's something happening right now, and just for you to be aware and try to help you know what to do with it. So other organisations, environmental health, put these out too. And biosecurity for this one for avian influenza as an example of things that go out. This is probably the most popular thing that we have, the most highly requested. I've left heaps of them behind. The fishermen love it. People really love this. So it's the salt marsh mosquito and the biting midge pest calendar. So you can try to predict the days you're going to get the worst mosquito bites, get pested the most, because they are related to the tides and to moon cycles and related to the rain. And so we kind of make our best guess every year at what the worst day is going to be. It's a bit of psychic prediction. But, we have this on our internet websites. You can download them, print heaps of them, hand them out. Anyone who likes going out on a boat likes to know about these. So just on mosquitoes very quickly, some of the diseases we have that are mosquito borne in the NT, we get Ross River virus and Barmah forest virus every year. Plenty of it, probably have seen some in your time. We have mosquitoes that can carry Murray Valley encephalitis and Japanese encephalitis virus. So hopefully we don't see too much of those, and we haven't for a number of years. And Kunjun rarely as well. But some of the things that can come in the Northern Territory, we do get a lot. We have a lot of people travelling overseas. We've got lots of Southeast Asian neighbours close by that people do visit. So we get lots of cases of malaria. We get dengue, which is unfortunately actually endemic in Queensland now too, in the far north. Chikungunya virus, we had heaps of that last year out of East Timor, and Zika virus from lots of places. So just on those, malaria, we actually do have a mosquito in particularly the Top End that can carry malaria. There's been a few times where like we need to know about these, even if you're not planning to test them, even if you've seen tons of malaria in your life and you're confident you know what it is and you're going to treat it and you've got it under control, we still need to know, because our Mozzie mob will go out and set traps around the house, try and assess what the risk is for the mosquitoes of having picked it up off the person and potentially have it in their little mosquito bodies. We just don't want that to happen. So we also track down the people that people might have been traveling with, so co-travelers, and might screen them to make sure they don't have malaria. So public health actually has quite a bit of work around malaria. So important if you see one to just pick up the phone and let us know. Probably our other really popular posters. This is Time Out poster. These are really long, so difficult to download and print, and that's why this is cut into 2 A4 halves. But we have hard copies that are a continuous, long, big poster. And if you'd like one, let us know. We can post them out to you, or the next time one of my nurses, Kim, comes to see you, we'll bring one along. But these describe the periods of exclusion for children from schools and preschools and childcare for lots of diseases. And again, not all of them notifiable to us. We've got molluscum on there, thrush on there, worms and other sort of gastro bugs, and it just gives you a guide for how long people have to stay away if they have to. Also on our website. And then the last thing, so I mentioned about, some things you have to notify as clinicians. This is a list. So on the left side of this, and I've got heaps of them laminated and printed out here too. You can just stick to your desk. is a list of all of our notifiable diseases and which ones doctors are legally required to notify us. But what I would say is for the ones where there's doctor and lab, if you know you're doing a test and you're sending it off to the lab, you can pretty safely assume the lab's going to tell us. So the main times for these is to pick up the phone is if you're not going to do a test or for some reason think it'll come back negative, but you're absolutely sure, and that happens with chickenpox, happens with shingles, malaria, we just talked about, just pick up the phone and let us know. Or send in the form. Either way, we're very happy. So we'll get into the topics that I promised we would do today. And the first one being measles. So measles being a highly infectious, probably the most highly infectious communicable disease that we have for people who are susceptible. So we've got pretty unwell, sad looking kids on this slide, and they do, and adults turn up. Adults can get quite sick from it too. But the conjunctivitis is a real sort of key part of this measles. They're watery, really red, really irritated, and just look miserable. We've got characteristic macular-papular rash, starts on the face and the neck, spreads everywhere else. And the pictures we see of the textbook are these like densely condensed, like impressive rashes. But sometimes it looks like this little guy's face where it's just kind of patchy, almost would sort of not think too much of it. And on darker skin, it actually doesn't always look red. So certainly can just look a bit dark, a bit discoloured, doesn't stand out like a wool. Now we talk about Koplik spots all the time with measles, but I think unless you're seeing high volumes of measles cases and really get used to what it looks like, they can be real hard to tell from anything else. So if you see these, watery eyes, rash, high fever, looks miserable, fine, just ring us and tell us and we'll help you get them tested. So just got a little scenario. I'm not going to actually ask everyone in the room because the webinar, we don't have time. But we have, in theory, a 7-year-old child, say walks into the clinic and they look really unwell. When you see them, they've got a fever of 39.5, a macular-papular rash that started on the face and neck. Mum says recently they've been to Melbourne, but they haven't been overseas. You can't confirm if they've been fully vaccinated or not. So the question is, well, what do you do? And it's a very good question, and we've seen it done lots of ways. But ideally, isolate them. We know that most of the time, the first time you've seen this kid is in your room. They've already been in the waiting room, so hard to isolate unless they walk up to the desk and say, I was a case of a contact of measles. I'm worried I have measles. Most of the time, you're not going to know. But as soon as you're suspecting, try and just put them in a space you're not expecting other people to go into for a while. Just try to isolate them. So it's spread by airborne droplets, and those can hang around for up to 30 minutes after someone has left the room. So try to avoid putting them back into waiting rooms, back into public spaces, and for every clinical space or space they've been into, clean it, disinfect it, leave it alone for 30 minutes, but then you're right to carry on as usual. So when there's a case of measles, we will ring up the practices. If they've been into your practice, we'll ring the manager and ask them for a list of people who are in the waiting room, and we'll ask it for them 30 minutes after the person has left the waiting room, or indeed sometimes after they've left the building entirely, and it's to cover that little period. That's why we ask. So the next important thing is to test them. So for measles, a urine sample, a throat swab, and a nasal swab up both nostrils, and asking for PCR measles on all 3 of those things, and send all 3 of them to a hospital base. So not to Westons, not to Sullivan Nicolaides, try and get it to tertiary pathology. So this is one of the things CDC can help you with, and will help you with after hours as well. Is that if you are struggling, if it's not your usual health, it's not your usual pathology provider, and the mechanism doesn't seem right, CDC can organise a taxi, pick it up from your door, drop it off to the hospital. Just no dramas, no worries for you, and we will do it.
Can I just confirm that's
Yes.
a separate throat swab and a separate nasal swab?
3
two PCR swabs.
2 PCR
Yep.
and 1 urine. Okay. So the most important thing here is to not send suspected measles cases into pathology centres to get that collected, just because it exposes another 100 or so people to do that. So if you call us and you're not sure, we'll help walk you through how to get this test done, where to send it, and then help you follow it up. If you haven't done it already by now, call the CDC and let us know. Even if you're just suspecting, as I said, we can give you some advice about for isolating the person. You know, can they go home and just stay in their room? Do they need to go to hospital? We can help you work through that. and also for that early advice to family or whoever is with this person, and also get those tests run as quickly as possible. It helps us too, because then we're ready to jump into action as soon as that is. And it's always on a Friday afternoon. That is always when it happens. So the reason that we are so antsy about measles in public health is that the management of measles is pretty straightforward from your point of view. It's supportive care only. It's Panadol, fluids, rest, hospital, things get worse. But for us, it's an extensive, rapid response in trying to stop it from spreading far further. So people who are immune, we think are probably born prior to 1966. We think they probably have measles and they're probably immune. So we don't prioritize them. People who are immunocompetent, so that's a double negative, non-immunocompetent, and they've had 2 doses of measles-containing vaccine, and you can prove that with documentation ideally, or they have evidence of immunity. So most of us in healthcare at some point had to do a serology to prove that we've got immunity, so that's also viable. So all those people, we go, okay, you're fine. Here's some symptoms to watch out for just in case, and leave them be. But the people we're trying to find are susceptible or not immune. So if they're born after 1966, they haven't had 2 doses of a measles-containing vaccine, they've got no history of having measles in the past, and no history of any immunity in any other way, then we might be able to do something for them, but it's really time limited. So our post-exposure measles vaccination or prophylaxis, we have to give within 72 hours for it to do anything. So we're really, and that's from the first time the person has seen the measles case. So we are so time limited with that. So this is why we want to get onto things as quick as we can. Alternatively, we can give normal human immunoglobulin beyond 72 hours to people who we think are at risk. So young babies, people who are pregnant as well and can't have an MMR vaccine, people who are immunocompromised or in other way, some way vulnerable, then we might give that out. So for context, the case that we had at the end of January, who was in his 20s, had actually spent most of his infectious period in Cairns on a great Bucks weekend. Lots of venues in Cairns. In here, he just had a family gathering and 2 visits to the ED, and that still generated 170 contacts for us to trace and find and do this assessment. And out of that, we gave, I think, 1 dose of NIG and maybe 4 or 5 vaccines, because it takes time to find people, and we're so restricted in our window here. So this is why we get so funny about just tell us even if you're not sure. That's measles. So across the country, measles numbers are up this year, with 72 so far, and 27 of those are in Victoria, 21 of them are in New South Wales, and more than half of those were actually acquired in Australia. So we've got local transmission happening now of measles, particularly in Victoria. WA have also had some local transmission. The cases acquired overseas, Vietnam, Indonesia, Pakistan, lots of Southeast Asian countries again, so lots of close neighbours for us. And I mean, so this snapshot's taken from the National Notifiable Diseases Surveillance System dashboard. This is actually public, so I put the URL here. And I should have taken a screenshot of the whole thing. But if you Google NNDSS dashboard or any combination, this dashboard will come up. And so for all the 70 nationally notifiable diseases, you can search for one, search for all of them, have a look at the trends over time, see the state and territory breakdowns, have a look at the breakdown of male and female and the age for those diseases. So that's publicly available. So why they're on the slides and why we can send it around. But it's a really great resource to just have a poke around if you're interested. But yes, measles is around. And so on this trend, it kind of looks like we'll look back at like 2014, there were 339 cases. It's crazy. Problem is that since 2020, we've had a decline in coverage of vaccinations. So on a national level, we've gone from about 94% coverage for measles down to 92. 2% doesn't sound like a lot, but when you think about measles, how quickly it can spread through susceptible people, that is actually a lot of people, hundreds of thousands of people potentially. over time. So that's why we worry about measles. But yeah, so the trick in the STEM at the beginning was the travel to Melbourne. So in past years, that probably would have discounted. We would normally say if they haven't been overseas, risk really isn't that high. But now, with some ongoing transmission and interstate travel and the constellation of measles symptoms, would be suspicious and would probably test them. So that is measles, and like we're doing questions at the end. Great. Come back around to measles, I'm sure. The next topic is pertussis. So this is a little more NT, probably the most of the 4 topics we're talking about. This is really going on in NT. So this is a graph from that national dashboard that looks at all the states and territories and that sort of trend over time. As you can see in 2024, big spike. This goes all the way back to 1994. So in 2024, we had the most cases of pertussis across the country that we've ever had. We had over 57,000, most historically, since we've been counting it. So it was a huge year for pertussis, and it's continuing. So in 2025, we're up to almost 13,000. We're not even halfway through the year. See the bigger states, Victoria, New South Wales, Queensland, carrying those numbers still. For the Northern Territory, we had 114 cases last year. We've got 47 this year, and they kind of looked like this. This is NT specific stuff. So we had a couple of cases in January that slowly increased over the year. And then around September, it really took off. We had lots of cases being reported. And I say this is probably tip of the iceberg in what's actually happening out in community. These are just the ones that we know about. But that sort of downtrend through this year probably isn't so real, because the cases that we are catching still are not epidemiologically related to each other. They just seem to be popping out of nowhere, which we know doesn't really happen. But that link in the epidemiological chain, we can't find it between a lot of people. So we'd say there's a lot in community that's not being tested, maybe not being reported, or we're just, it's just kind of still rumbling anyway. We can see Darwin in the blue had a lot of the numbers last year, and so did Alice Springs, but then we've kind of got Catherine and the Barkly in the last 6 months or so that have been seeing more cases than probably is their fair share. So then the other point to make here in that little graph next to it in the blue, this is the age of the notifications that we've had in the NT since the start of last year, and most of the cases are in children. 24 of those cases in that first age group were in babies less than 1 year old. We've had lots that have been a couple of weeks, 2 months, 3 months, lots of young babies. Fortunately, we haven't had any deaths, a couple of hospitalizations, quite sick, but not any negative outcomes yet. But then the second peak is in the kids around 10 to 14 years old. Kind of not really surprising, as I think with this big pertussis outbreak last year, and really looking at the trends, I think we're sort of suspecting that probably the peak coverage for pertussis is around 4 to 5 years from that vaccine, and then it really starts to wane because everyone's seen this in the kids aged 10 to 14, which is that perfect, the last vaccine would have been around 4 years old, kind of couple of years down the track, sort of 8 years, 9 years, 10 years, getting pertussis again. So I think it'll spark some really interesting research and maybe some changes around recommendations. Who knows? That's a personal theory, not a fact. But definitely a sort of trend there with those kids, and those numbers are quite obvious that something's going on. So in terms of case management for pertussis, so it's characterised by a sort of common cold, upper respiratory tract infection symptoms, but then that cough just keeps going for weeks, get really bad at night times. But something to note, even though we call pertussis whooping cough, very young babies often don't whoop, but they gag, they can gasp, they can hold their breath, sometimes they turn blue, rather than that classic whooping in intake of breath. The same for teenagers and grown-ups. They also don't really whoop very much. They just have this really awful, persistent cough. Sometimes it makes them vomit, sometimes it doesn't. But it can not always look very classic, and certainly the cases we've had notified to us haven't all been very classic. So people with pertussis are infectious from the start of those ERT symptoms up until 3 weeks later, so 21 days onwards. So from their first fever, their first sniffle, within 21 days. So if we put them onto treatment with antibiotics, that's azithromycin, really, that will shorten the infectious period and they can go back to work, to school, to childcare after 5 days of those antibiotics. Otherwise, they've got to be excluded for the 21 days from the start of their illness. So 3 weeks is a long time to be locked out of childcare, locked out of school, locked out of work with vulnerable people. So, I mean, obviously, if you catch them at like day 16 and it wouldn't make a difference either way, fair. But it's a sort of case by case assessment for whether that would make their life better, as well as in symptoms. It does seem to help a little bit symptomatically as well, though it depends. If the longer the cough's gone on, the less the antibiotics. So for this one, it's another PCR, but a nasal swab. It's the best test for pertussis in someone who has symptoms. The serologies can be difficult to interpret. They're better for once they're kind of 3 weeks or longer into their illness. So for contact management from our point of view, public health's point of view, we're looking for high-risk people who might need antibiotic prophylaxis in the contacts. So it's really centered around babies less than 6 months old. So if they are a contact themselves, then we're also looking for people who might spread pertussis to babies who are less than 6 months old. That could be parents and carers of babies that live in the house and other household contacts if the baby is not the case. Could be healthcare staff who work with babies, so often paediatric wards and NICUs in particular. We tend to go pretty ham on the antibiotics just to be safe. Childcare employees and kids who go to childcare, we might also give them antibiotics if we think there's a risk of passing it onwards. This is sort of assessed case by case and tends to be where CDC, we often will do this and try to, like, it's very, if we have a conversation with you and you go, oh, too busy, we go, great, we'll call the person. If you're happy, we'll find all these people. We just might need help writing out the scripts for the antibiotics that they can come and pick up. So this table outlines the antibiotic treatment recommended for giving it to people for post-exposure prophylaxis by their age group. This is from the series of national guidelines for pertussis that CDNA, the Communicable Disease Network of Australia, put out. Googleable, publicly available. It's our kind of Bible for how we do public health response, but that's what we're going to recommend.
Hang on, just on what you were talking about, yes. The question has come through. I know we're doing them after. I don't know if you want to answer it now, just in case whilst it's hot.
Oh, what a good question. What factors were responsible for the increase in the number of pertussis recorded in 2024? I know we blame a lot of stuff on COVID, but a little bit might be COVID. So pertussis is a cyclical, like every 3 to 4 years, we seem to get outbreaks at a national level, and that pattern was kind of trucking along until we hit COVID, and then it really took a break. And I think there's a combination of waning immunity, drops in vaccination rate across the board, just a general susceptibility that people seem to have now to diseases that we had a real break from, and now it's just absolutely taken off. But I think it's something there'll be lots of evaluative studies and research into really looking back on why we've had resurgence of things other than just we shut the borders, because it seems too simple. But yeah, there's probably lots of things at play. But great question. Welcome. Last minute plug for vaccines for whooping cough. So they are on the National Immunisation Program at intervals that I can't remember off the top of my head, because the immunisation team, that's all they deal. But in childhood, we have free vaccines for whooping cough. In pregnancy, for every pregnancy, whooping cough vaccine, usually around second trimester, it's recommended. Getting boosters in adolescence and adulthood, you know, a great trigger for adults is, oh, my friend is pregnant, I'm going to get a shot. You go, great, do it. Let's give them a shot. And finding any reason to try to top them up, particularly with potentially some waning happening in that 10-year period, maybe being a bit too long. Next, Mpox. So, got a couple of resources on here for Mpox, previously called monkeypox. These are two different approaches kind of communicating the same thing. One from the Interim Centre for Disease Control in the Australian Commonwealth and Department, and one from the Aboriginal Health and Medical Research Council in New South Wales, giving similar information just in different ways. There's lots of resources out there you can print and put up for Mpox. But it is a viral illness in the same family as smallpox, kind of chickenpoxy. I mean, some of these little lesions look a little, vesicles look familiar. But it is characterized by a papula, which then turns into a vesicular rash, then crusts and scabs. Sometimes it can also be present. We just have proctitis without rash, without any other symptoms, just proctitis. We've had a number of Mpox. I say we as in Australia, not BNT, have had a number of cases turn up like that. Other symptoms for Mpox can include fever. Headache is a really common one. Lots of people just feeling really fatigued, really headachy. A lymphadenopathy can turn up, and as well as joint pain. And so the rash, we've got a few examples here. Sometimes you can get clustering of these lesions together. Sometimes it might just be one little spot on the face, one little spot on the hand, and that's about it. Most common spots for these to turn up tend to be we think it's probably to do with the points of contact usually. So it's genital area, hands, mouth, across the chest, and also on the feet sometimes. But the spread of Mpox has been a really interesting thing to watch. So in January 2022, around then, we started to see a breakout of Mpox, which is not, it's not a new disease. It has been in Africa and Central African region for lots of years, but hasn't sort of expanded globally in the way that it did in 2022, just suddenly took off. And so the Mpox that was circulating was clade 2, tends to be 2 clades. Clade 1 seems to make people more sick. Clade 1, it's a bit more serious and transmits in slightly different ways. Clade 2, which is a little less serious, and that's the one that's kind of gone across the world. So this map's really interesting, given that talk about Africa and Central African countries, a lot around Mpox. And then when you look at that graph and this map, the confirmed cases like USA, Brazil, even us, China, Canada, everyone's kind of outstripping these countries. And partly that might be that we are counting more carefully. There's a bit more ascertainment and public publication of data, but also just because our mode of transmission, I think, is a little different. So this graph is, I think, an interesting way to look at it, this diagram. The Mpox in endemic settings, so where Mpox comes from originally, it's a zoonotic disease, so it lives in animals. Even though we called it monkeypox, monkeys aren't really the reservoir. We don't think they're probably the main reservoir, actually, and not the reason that it's spilling over into people, but the animal is not, it's not really well understood yet. But there's some spillover from animals to humans, and then some limited secondary house-to-house transmission, mostly kept within households, but not widely. So it's kind of how it's been contained for lots of years. And then in 2022, with the sort of escape globally, the transmission pattern has been different. So it's human-to-human transmission. It's primarily through sexual contact, and maybe there is some difference in having dense sexual networks. We've got a little bit of a change maybe in this clade 2b, that even with no symptoms, we're still shedding virus and seeming to be able to pass it on a little bit. But it's really still being explored why this has exploded. Get on top of that question before it comes. We don't entirely know how this triggered and why it suddenly just took off. But it is clade 2b that's been going globally, and it's disproportionately affected gay, bisexual, and other men who have sex with men. That's been the case in Australia as well. So we had the first few cases in 2022. So we had 144 that year, and most of those were acquired overseas. And then it just sort of went away for a bit. 2023, very few cases, didn't see much of it. And then last year we had a big resurgence in clade 2b. And almost all of those have been men, and all of the ones that we typed were clade 2b. And 85% of them now from 2024 have been acquired in Australia. So we got sustained, almost endemic transmission of Mpox in Australia now in quite a significant proportion compared to when we first saw it in 2022. So the cases were really concentrated around East Coast capital cities. So you can see in those numbers, NT, we just had 4 little cases last year. We had one early last year who was a return traveller from Africa. And then we had 3 all close together in October. One clearly interstate acquired, and the other 2, one was really uncertain, and one we think did catch it here, but not because it's in the community, but from another traveller also moving through from an event or something. Just because we did not see it more, and we haven't seen any more notified yet. So I think the interesting thing about Mpox, because the mode that we're talking about is sexual contact. So it's not really like a sexually transmitted infection. It's not an STI in the same way as chlamydia and gonorrhea. It behaves differently. It's transmitted through skin-to-skin contacts. There's lots of ways that you can catch this without it just being sexual. So we don't really put it in the same basket as STIs. And I think this is just another way that it is different. And this is a graph again from that national dashboard, which sort of shows that the common ages for this Mpox really are around those 30s or even getting to their 40s. They're much older men, whereas our other STIs you typically see 15 to 24-year-old, maybe hetero networks. Like it's a different thing going on. Yes.
It's easy to recognize. It looks like off.
Yep.
Lots of other things.
Yeah. Well, it looks, I mean, even the one on the chest looks like it could even just be an infected chest hair. Like it just, yeah, and it does look like lots of things, and even syphilis can kind of look like a little tiny chancre. It's difficult.
Very difficult.
To pick it. Yeah.
Even just to think about it.
Particularly in the NT when we've had 0 cases this year. And so we're really not thinking about it. So I guess it's where for rashes in those kinds of places that this history taking, getting into it, so saying, when did this come up? Did anything happen, around to bring on this rash? Depending on how you're feeling about that connection with that patient, to dig into their history and say,
They're
are
all
there any risks?
mostly homosexual, pretty much all of them.
Yeah. And the couple of females that we do have in this were because they had sexual contact with someone who is bisexual and was also having sex with them as well. So it wasn't through exclusive heterosexual networks at all. That the female cases up there tend to be. So for Mpox, if you've got someone who you do have made the mental leap, the jump, and are suspecting it, so the most important thing is to take a test for them. And so this is another PCR. We're really loving our PCR today. So taking a PCR swab from at least 2 lesions if they have that many and if they're visible. And when you do this, it's important to put on a gown, put on gloves, a surgical and N95 mask, and some eye protection just to be really, really safe. Mpox vaccination is not something we sort of routinely recommend to all healthcare workers at the moment. So if you are suspicious, it's best to just be protected, particularly if you haven't been vaccinated. And so while you're there, important to remember to test for syphilis and other STIs because it can overlap with lots of things, and it's just a good opportunity to have that conversation and do that test. And let us know. So call the CDC or Clinic 34 in work hours directly and let them know if you suspect an Mpox case, because again, we can help that testing get taken from you to a lab quickly. We can give you some advice on the spot about managing that person. We sort of have some different rules for clade 1 versus clade 2, but that's really based on risk. So we can help you ask some questions and give some advice in that moment if you need it. For Mpox, we tend to just do the contact tracing because we like to follow them up. We kind of stalk the contacts afterwards and see if they've got symptoms and see if they need a test. So we'll just take all of that on. You have to let us know.
Yeah. With the PCR swab, can you just do the one swab and you can take the syphilis PCR from that swab?
Yeah. Actually, no, sorry. They've got to be 2 different ones because I think our lab at the moment for Mpox is sending it away to validate it. So they'll.
Okay. So if we're worried about syphilis, we would take 2 swabs and send it off.
Yeah, 2
probably
PCR.
Okay.
Yeah. Very good pickup. Thank you. Oh, that was quick on Mpox. So the last topic we've got to talk about today, and then hopefully we've got good time for some questions. So avian influenza was the last topic to talk about today. It was when we were setting this up a few months ago, maybe a little more topical, current, urgent in Australia, since reduced, but still good to talk about it. So avian influenza, so the type that we worry about in humans is particularly H5N1. So this little graph from the American CDC said that's some really interesting things happen over there with their transmission pathways. It does say cats. I will get to it. So the reservoir for avian influenza is wild birds. So we always talk about the chickens, but they're kind of down the way. So the wild birds are housing different types. And so H5 types are one. They also have H7. There's lots of types of avian influenza. But they come in contact with other animals that then have more contact with us. So they, in contact with chickens, they might approach the feeders in the backyards or on farms and have their nasal secretions go in water that then the chickens drink, or they just sort of intermingle in the yards if you're not keeping them out. Obviously, cows out in open farming have a lot more interaction with wild birds, with their excrement, with their products, with things going on. And also cats, because cats will chase these and catch them and eat them and bite them and interact with those fluids as well. And so even though the cats haven't spread it to people, the US has found a number of avian influenza episodes in cats, and they were pretty severe, and I'm not sure a lot of the cats lived, actually. It makes them very sick. But then from the chickens and the cows, then that's where the humans tend to have that more intense interaction, that risky interaction, and can then contract this. Probably important to note, once we've got human-to-human transmission of this happening, of like more than 1 or 2 cases, we would just call it a strain of human influenza. It stops being avian influenza. It becomes a new, with pandemic potential, or something, we call it something else. But for this, in this little step, it's still avian influenza. As I mentioned, it's H5N1 is the one we worry about for humans, and what has happened over in the US, they tend to be H5N1, but they are a type of influenza A. So what happens with those is that the way they present clinically can look really similar to influenza A, and on testing, on our little rapid antigen tests at home that we all do now, or on PCR in the labs, it just looks like flu A. So it's really hard to, it would be the most incredible feat to just spontaneously go, I think this person has avian influenza, test them and then be right. It's really difficult. So the key to this is really detecting risk factors. So if they've been overseas, they've been to the US and doing that, they've been interacting with cattle, with birds, any of these things on this little table, directly working with poultry or poultry products, or being the people who go and pick up the dead birds when someone calls them in, being the wildlife workers that look after sick birds, or even just having chickens in your backyard. That those put you a bit more at risk for avian influenza. So some of the main giveaway, and probably the cases in the US, so they're up to about 70 now, and I think Canada's had like 1. Something that we're seeing with those as a trend is that they tend to be mild illnesses, but conjunctivitis, they get awful red, horrible conjunctivitis, with otherwise a pretty mild set of symptoms, and they're people that work with cows and work with chickens, work in that space, and that tends to be the profile of who has been a human case overseas. But as you can see, a lot of those symptoms just look like regular flu, fever, sore throat, shortness of breath, runny nose. So really, really difficult to tell. So the way that this gets picked up, and we had our 1 case last year in Australia, and that was in a child who was in ICU and was quite unwell. And we didn't find out till 3 months after they got better and they got home, because the testing went off to the World Health Organization, as we do routinely send tests off to get looked at. They came back and said, oh, that's a H5N1. Did you know that? We went, no, we did not. I had to go back and sort of get more information about this child and where they had been, but they had sort of exposures to poultry in India. We're confident that it happened here, as well as not detecting any H5 strains in our poultry in Australia at all. So what did happen here last year is that we had 15 detections of H7. So H7N9 was probably the one that came up most often, or H7N8. And those viruses, we found them in birds, so particularly poultry farms in 2024. We had 4 of them earlier this year in 2025. So that resulted in decontamination of all these premises where the chickens and things lived, depopulation, which is a nice way of saying that we culled and killed the chickens, and then instituted movement controls. So may not be familiar, but your carton of eggs that you get is actually made up of eggs from chickens that might live on 7 different farms. So smaller farms of chickens send their eggs off to a larger place who sort through and package them up, send them on for distribution. So our egg shortage was more a result of that rather than of destroying all the eggs because they were dangerous themselves, but rather for all these reasons is why that happened. And so we instituted some surveillance of domestic and wild bird populations, so grabbing them and shoving little swabs right down their throats and in their noses to try to test them and see what's going on, and some of that is still ongoing. So at the end of April, now about 2 weeks ago, there was the deactivation of the National Incident Centre for Avian Influenza. So at a national level, we've recognised all those farms, all those detections have been resolved, gone, flu's gone. We've eliminated it again. We're in a good place again, but we're still doing preparedness and planning for avian influenza in the background. The interim Australian CDC's One Health division is still doing things. So even just last week, our team went along to talk about carcass management in the event of mass deaths or mass culling. So lots of things still going on in the background to make sure that we're ready and protected against avian influenza. But just to put it in context, we had 19 detections in total. In the US to date, there have been 1,600 outbreaks in poultry that's affected over 168 million chickens, and poultry and birds. They've had over 900 cases detected in their cattle as well. So the scale of it, we think about the huge national response we put into our 19 cases and could be much larger than that. But this is why we go so hard at trying to make sure it doesn't turn into this sort of situation. So some other quick plugs and we'll stop for questions and answers. So the MenB, meningococcal B vaccine catch-up program is running in the expanded program. So it's now free for adolescents 14 to 19 years old. It's a group that we're struggling to get in with, actually, the teenagers. They're hard to catch. If you've got any big ideas or advice for us, talk to the immunisation team and to learn more or give us some pointers or tips. Flu vaccine is here and so is the flu. So since January, February, we've had rumbling flu that's kind of gone up. It's kind of coming down now, but probably just in time to go right back up again. So it's a great time to start talking to patients about flu vaccine and working that in your conversations where you can. And lastly, a syphilis incident management team has been stood up in February by the Chief Health Officer. So this is to tackle syphilis. So we're in an outbreak that's been going on now for 12 or 13 years. And the goal of this IMT is to try to increase our testing and treatment across the board. So we are doing some sort of reflex testing. If someone gets a blood test done in ED at Darwin and Alice Springs, we're just doing syphilis serology on it. Got point of care testing stood up in the regional EDs and rolling out to some GP places, particularly the ARCHOs, to try to get that accessibility for testing up. We've got more people hopefully coming onto the syphilis register, and that's running after hours now as well. So you can call it on weeknights and over the weekends to talk to syphilis register operator. If you're unsure about the results that you've got back or want to know more information, assistance on how to treat it. But lots going on in syphilis, and I'm sure if they haven't already, they'll probably come and want to do one of these nights, I would imagine. But thank you very much for letting me get through all of that. So the phone number here is the Darwin number, but we just sort of look after the regions too. So if you're anywhere and you get stuck, you can just call that and we will help you. And me personally, I am also on the end of the phone after hours and can chat anytime. Happy to go into questions.
I might